Welcome, everyone. I'm Susan Hoffman, the director of the Osher Lifelong Learning Institute. Each term, we have the opportunity to ask questions of Dr. Deborah Gold, a San Francisco infectious disease specialist and a hospital epidemiologist. For 55 weeks, she has been providing briefings through the MAVEN project, providing the really most recent research around COVID-19 and sharing that with healthcare workers across the country. She's with us today, and as we have done every term, is we've asked members to send their questions in for Dr. Gold, and we will also take questions through the chat room. The thing we won't do this time is we won't answer questions after today's event. So if in fact you're not hearing your question answered, please feel free to put it in the chat room. We'll be reviewing that during this hour-long session. If we have to go to 65 minutes, we will, but we want to make sure that we cover what we can during this time together. Thank you, everyone who has sent in questions. And I think without further ado, let me just launch in to what's the current period that we're in right now. So many of us are vaccinated, businesses are opening up, and yet we hear from the CDC and others in the medical establishment the concern that they have about the surge, the April surge, or Debbie, as you've referred to it, the fourth wave. Debbie, can we start there? Can you tell us what are the various factors that are leading to this surge? And we'll begin to get into the kinds of things that we need to be thinking about. But if in general, let us know the status of things.
So we're doing a lot better here in California, not only in Southern California, but also in like Riverside County and some counties that are very rural in the southern part of the state. Things are much better here right now. But there are areas in the country that are having are seeing rapidly rising cases. And in fact, looking at case counts overall in the country, we have been rising steadily over the last 2 weeks. This is largely because of increasing cases in the Northeast and in the Midwest, especially in Michigan. And those areas may be a preview of what we will see in the rest of the country in the coming weeks. And unless we can really roll out vaccine very quickly and convince people who are resistant to taking vaccine to go ahead and take it, we're going to be in trouble again, seeing a fourth wave. So why are cases rising? I think looking at Michigan might be a good way to explain it. There are the most common strain that is circulating now is the B117 strain that came from the UK. It is more transmissible, confers an increased risk of more severe disease and death. And so cases are rising in Michigan because of the increased transmissibility of this virus, this viral strain. And hospitals are filling up and they're getting into a rather dire condition there. And as hospitalizations go up, it'll be another couple of weeks, maybe 3 weeks before we start to see increasing deaths as well. So there are other factors in the country which are contributing to the rise of cases, and that is that governors are lifting mitigation measures too early in their states. And so people are going into our restaurants and bars in some states without any restriction on the capacity in those venues. And people are tired and just basically getting together, and there's more transmission and more transmission of more transmissible virus. And by the way, The more the virus replicates, the more it has opportunities to acquire mutations. And so the more transmissible, more lethal variants that are currently circulating have more opportunity to gain even more mutations, which might make them even more dangerous. Or a wild type virus that is also circulating and replicating can acquire mutations and can engender more resistant, more lethal variants just de novo, not from just from wild type virus. I hope that's clear. Anyway, so we're sort of dealing with the race between vaccinating people and the emergence and transmission of variant strains in a lot of the population right now.
And Debbie, for California, which are the variants that are occurring?
We have B117 here, which is the UK variant, but of more concern is Cal.20C, also called B1427/B1429. That variant, and it's confusing because it goes by two names, but it contains the L452R mutation in the spike gene, the gene that codes for the spike protein, which is conferring increased transmissibility. And in fact, I checked last night, 57% of all isolates in cases identified now in California are the Cal20C variant. So it's spreading very rapidly, and not only in California, but also in Nevada, Arizona, and there are Florida, New York, and Texas, and a couple, Missouri. So it is spreading its tentacles fairly widely and rapidly in other states as well. But here, 57% of cases are this highly transmissible variant. There have been only a couple of papers published about it. The main one from Cedars-Sinai, which was the one that described the variant. But as far as the increased transmissibility, I'm just looking at the strain-specific data that comes out from the CDC, and you can just see that the percentage of strains in the state of that variant are rising rapidly. But Charles Chu, whose lab first identified this strain, has said in an interview that it confers a significantly increased risk of mortality. I haven't seen those data published or even posted on medRxiv. And I actually sent him an email asking him, where are you getting those data? And I haven't heard back from him, and don't expect to, but I think that it's very worrisome for California that we're seeing such rapid spread of that particular variant. By the way, one of the monoclonal antibodies that was marketed by Eli Lilly does not have any activity against Cal20C. And about 2 weeks ago, Health and Human Services said that they would no longer distribute that monoclonal antibody, and it is a single monoclonal called bamlanivimab. They would no longer distribute it to California, Arizona, or Nevada because of the prevalence of the Cal20C variant there. And then last week, they said they would not be distributing that monoclonal antibody anymore to any state because of the worry that it will not have activity against the Cal20C variant and perhaps other variants as well.
Interesting. I want to remind people that this is being videotaped, and we will be providing it to all the members in the notes, which is delivered through the OLLI communications on Sunday. So if you want to go back to some of the things that Debbie has said, you can review it. And thank you for that. I think, so it sounds like we're running a marathon here, and that one of the things that we now have to be aware of is these variant strains. And can you talk a bit about how effective right now us who are vaccinated, how do we begin to see whether or not the variants are an immediate threat, or is it something we need to be looking for?
Yeah, that's a good question. So we don't know about real life. We don't have real life information yet about this, since people who get breakthrough infections, and we know that people are getting breakthrough infections, there haven't been any publications, at least that I have seen so far, describing those individuals. Are they breaking through because they have been infected with a variant, or are they breaking through because they are immunosuppressed in some way, or because they're very elderly, or for some other reason that we haven't identified yet? So, what by breakthrough, I mean an infection that occurs in a fully vaccinated individual. But we know from in vitro studies that the serum from people who have been fully vaccinated has good activity against the B117 or UK variant. So it is likely that people are well protected from that, but we have to see some real life data to back that up. We know that serum from vaccinees, and these are vaccinees from Moderna, Pfizer, and J&J. Those are the ones that have published their data. They have statistically significantly decreased activity against the B1351 variant, which is the South African variant, and also against the P1 variant, which is the Brazilian variant. I don't know if I have seen data for B1525 and 526, which are the New York variants that are circulating increasingly in New York and in the Northeast. I don't remember seeing, or I may have seen it for Pfizer and Moderna. I can't remember, but for sure there is decreased activity against the South African and Brazilian variants, and maybe sixfold decrease in titers. In other words, you need much more concentrated serum to neutralize a pseudovirus that expresses the spike protein from those variants. But again, we need real life information about people who have been fully vaccinated and have developed breakthrough infections. And these are being posted like every day. I see them on my Emerging Infections Network listserv. This morning, there was a 60-ish-year-old man who required hospitalization for a breakthrough infection. And it turned out that he had chronic lymphocytic leukemia that was not diagnosed before he had his vaccination, and therefore did not respond to his vaccination. So that was a good explanation for why there was a breakthrough infection there.
I'd like to stay for a moment. We have a number of different questions that came in from members who have an immunosuppressant situation. And so I'm going to just describe their situation and get your response to that. One is a recent kidney transplant patient and his spouse who donated her kidney to him are very concerned about the fact that they are taking immune suppressant drugs, and both of them have been vaccinated. Are they in a danger area?
Okay, so there were no immunosuppressed individuals who were included in the phase 3 trials of any of these vaccines. Mm-hmm. So we don't really have good data on how those individuals respond to the vaccine, whether they mount a robust or durable response to vaccine. That being said, there was a recent paper published looking at the antibody response after the first dose of Pfizer and Moderna. I believe most of the patients got Pfizer, but there were some who also had Moderna. These are patients who were recipients of solid organ transplants, so not bone marrow transplants. Most were kidney transplant recipients, but there were also heart, lung, pancreas, and small bowel in that mix. And some were multiple organ transplant recipients. And it was concerning that about 2/3 of the individuals who had received a single vaccination with either the mRNA vaccines did not mount any antibody response to the vaccine. And that's not to say they didn't have a T-cell response to the vaccine, which is much harder to measure. We are eagerly awaiting the next publication from this group, which will reveal whether they made antibody after the second vaccination. But until those data are published, I think it would be a good idea for people who have had solid organ transplants, especially who are taking mycophenolate in their immunosuppressive regimen, assume that you are not immune and continue to practice all mitigation measures, and be on the lookout for the publication, the second publication, which will definitely be in the New York Times, the Washington Post. I think there are a lot of people who are really interested in that, and it will be in the lay press.
Here is another specific example from an OLLI member who is immunosuppressed. 4 weeks after my second Moderna vaccination, my internist ordered the workup for my IgG and IgM spike protein antibodies. Both are negative. Is there any new information or advice for the immunosuppressed? Would this be the same?
So when these patients are being reported just in the listserv, they too don't have any antibody to spike IgG. No one's been measuring spike IgM. And because we just have this limited data about the humoral immune response and nothing about the cellular immune response, I think the safest thing would be to assume that there has been an inadequate or non-robust response to the vaccine. And especially if those labs were done at a time when you would expect to see a very high level of antibody, of IgG. I think that you should assume that you are maybe not protected, and again, practice all mitigation measures. Yeah, and eventually there may be some recommendations that come out saying individuals like this should then go on to receive a different kind of vaccine. Like if you got an mRNA vaccine, get the J&J or get the AstraZeneca or whatever is available. But I think for right now, I would be conservative and assume that you are not protected.
And then for people who have an autoimmune disease, whose bodies overreact to the vaccination. Any thoughts about that? I know that some are basically, their practitioners are telling them not to take the second vaccine. And so their questions are they protected as well with one dose, or should they continue to have the current measures around safe practices? So
I'm not sure what overreacting to the vaccine means. I think that there are not good data to suggest that people with autoimmune disease have flaring or worsening of their autoimmune disease that's precipitated by vaccine. So there's certainly nothing in the literature that I've seen. And when I do these Maven talks, there's a rheumatologist who keeps up with the COVID rheumatology literature. And he has told me just offline that he has not seen that kind of data published in the literature. So I would say that taking a single vaccine is a gamble. And if there was some maybe flaring that could be treated with a short burst of steroids or something like that, I would go ahead and take the second vaccine. The reason is that you need the second vaccine to get durability out of the vaccination process. So you may get a robust response initially, but you really want to have a durable response, and that requires a second vaccination. That's why we give kids, when they get their first flu shot, they have to get 2 in order to get a durable response that will last them for the whole season.
Let's stay with that for a moment. Let's talk about the durability and what do we know?
So the CDC is still stuck on this 90-day business because I guess the best data say that we have protection out in 90 days, but there are really very good data to show that we have good protection at least 6 months. I have also seen some data for 7, 8, and maybe 9 months. And I have a paper in my pile of papers from this week that I need to review that looks like 9-month data. Remember that the phase 3 studies were only started in May. So we don't even have a full year of following individuals who participated in the phase 3 who were first in line to get their vaccinations in May, because it took them several months to complete enrollment. So it's going to take us a while to know what the exact durability is going to be and whether it's going to carry us through a full year. So we're going to have to stay tuned on that.
Let's also return to the question about viral load. And vaccinated people generally can't get the virus. But the percentage of people that are, as you referred to, have a breakthrough infection. Can you give us some way of, all right, we're going to move into this kind of, all right, post-vaccine world. All of us who are vaccinated are wanting to figure out how do we proceed with normal life. And so the question is, how protected are we?
Yeah. So I know that Rochelle Walensky the other night on Rachel Maddow said, well, people who are vaccinated don't get infected and can't transmit the virus. And I think the CDC had to walk that back the next day, because there's no such thing as a perfect vaccine. And the closest that we have to a perfect vaccine is measles, and that's 97% protective. And we occasionally see patients who have been fully vaccinated with MMR as children presenting with measles, and it happens. And so this is similar, that even though there is going to be a 95% effectiveness in protection from infection, there are going to be people who, for one reason or another, don't respond in a robust way to the vaccine and will not be adequately protected. In the same way, we are just starting to see some publications, one of which was from the CDC, one was from UCLA and UC San Diego, looking at the question of whether people who have been vaccinated can become infected and not exhibit symptoms, or who can get asymptomatic infection. And those individuals theoretically can spread infection to others without knowing that they're infected. Now, we know from some of these early publications, and literally these have been in have been reached publication just in the last 10 days. It looks like after one vaccine, and these are done, by the way, in healthcare workers. So I want to say another word about that, because healthcare workers are usually young, healthy, largely women, and don't have comorbidities. They seem, the vaccinations, the mRNA vaccines, confer an 80% effectiveness in protecting against both symptomatic and asymptomatic infection. That's after one dose. After 2 doses, it looks like the protection was 90% against symptomatic and asymptomatic infection. Now, how do we know that these healthcare workers didn't get asymptomatic infection? We know that because at UC San Diego, starting on December 2nd, they started testing all their healthcare workers with PCR every week, whether they had symptoms or no symptoms. So we know the protection was 90%, that there was a 90% drop in healthcare workers who tested positive on their weekly tests. It means that 10% of their healthcare workers would have a positive test after they received 2 vaccines. So there are some individuals who will get infected after they are fully vaccinated. We don't know anything about their viral load, which is the amount of virus that they carry, which would dictate how transmissible they are. So I think that those data are coming. There's a great interest, in, at least on my part, in people who are breaking through, both individuals who break through and get symptoms, and especially those who get symptoms and have to be hospitalized, but also those healthcare workers and first responders who test positive after they're fully vaccinated. How much virus do they actually have, and what is their potential to spread to other people? So we don't have that information right now, and it's a big black hole.
And Debbie, is it true or false that no one who has been vaccinated, the double vaccination, has died of the virus?
So there's 100% protection against hospitalization and death in the phase 3 studies.
Mm-hmm.
And that's true of Moderna, Pfizer, and J&J. The AstraZeneca data are coming. They have not yet been submitted to the FDA, so I haven't seen those phase 3 data. That is not to say that there are some individuals who have been fully vaccinated who have been hospitalized. Certainly this guy that I read about this morning who was hospitalized with very severe pneumonia because he had undetected chronic lymphocytic leukemia and didn't respond to the vaccine. So there are going to be people who will get very sick and require hospitalization. And I am looking for publications about those individuals. We know that in Israel, where they have vaccinated a very large percentage of the population, they have seen 907 symptomatic COVID cases in people who are fully vaccinated. I have not seen any publications yet describing that population. How sick did they get? Were any of them hospitalized? Did any of them die? Did they have underlying conditions? Were they very elderly? I'm worried about that because my 90 and 95-year-old parents are now vaccinated, but did they mount a robust and durable response to the vaccine? I don't know. I do want to say that there was a publication that hit my radar yesterday. I think it was just published this week, that looked at individuals in the UK between the ages of 80 and 96, which just really got my attention. I immediately sent it to my sister, who's an internist, saying, look at this, Mom and Dad. It looked like those people in that age group who have a diminished ability to mount an immune response to a lot of things did mount a robust immune response to the vaccine. So, and I don't know if they got AstraZeneca or got Pfizer or Moderna, but it looked like they had a good antibody response. So I was relieved to see that. But I haven't read the paper in detail yet. I just sort of saw it and then CC'd my sister on it.
Debbie, the CDC, let's talk about the credibility of the CDC at this point with the new administration, and knowing that that there is still some difference of opinion. One of our members writes in that the UCSF medical staff does not agree with the CDC guidelines of vaccinated people mixing indoors unmasked with 3 households of other vaccinated people. And then the one the other incidents of mixing indoors with one unvaccinated person. So all of this seems to be a bit of a gamble. Can you give us any kind of read on the CDC? Do we go with the CDC or do we go with our local experts at UCSF? How do we begin to sort of, we want to widen this path of safety. So what's the best authority?
So I'm not sure about what UCSF voices are disagreeing with the CDC. I think that Monica Gandhi is doing her own shtick. Bob Wachter is doing his own shtick. There are a lot of factors in that how do I put this? There is a lot of politicking that goes on, especially in individuals from UCSF who like to be on TV and seek a lot of TV coverage. I would say that is particularly true of Monica Gandhi and Bob Wachter. And they might disagree with the CDC, and that's fine. And there are people who might go, and even George Rutherford, who is the most trusted voice from UCSF, says that the CDC really needs to do something about their statement about travel, that they're really overdoing it. But I think that on the whole, the CDC is back as a trusted institution. There was a purging that went on after Rochelle Walensky came into office as the director. And the deputy director went through and they purged all of the kind of questionable stuff that was still in the CDC archive or still available to the public. And that was that was written by the White House or that was dictated by the White House under the previous administration. So I think the CDC is doing a great job. They're doing the COVID updates Monday, Wednesday, and Friday. I think they're being quite transparent. And I believe the publications that I'm seeing coming out. To me, it was obvious during the last administration when I was seeing these very weird MMWRs or just weird things on the CDC website about COVID testing and quarantine requirements. It just seemed nonsensical to me, and I'm not seeing that kind of thing anymore.
Let's talk about the CDC guidelines on travel. What are they currently and where do you expect they're going to go?
So I think that the CDC is still being very conservative about travel. They're recommending against travel that is non-essential. I think that they are going to loosen up on that. I thought they might have done that already. But I think for vaccinated people, it may be going overboard saying don't travel at all. I think they're really worried about spread of variants. For example, if people in California who are fully vaccinated can be asymptomatically infected with Cal-20C and then go on an airplane and take it to the Midwest or take it to the South or someplace that doesn't already have that variant. I think that's what they're afraid of. But so they're continuing the recommendation about travel, although I would be following because I just really think that they're gonna change that sometime in the near future. They are still putting a very strong recommendation against cruises out there, and the cruise industry is ignoring that. And I know that, oh God, I can't remember if it's Royal Caribbean or I think it might be Royal Caribbean that is going to start cruises in June. And I know that other cruise lines are just chomping at the bit to start cruises up again, requiring people to be fully vaccinated. It is possible now to buy false credentials for being fully vaccinated. It's possible to buy fake testing results to get on airplanes. And they cost $150 each if you're interested. And so anyway, I think the travel on cruise ships, I would just say, I have two words for the cruise industry: Diamond Princess. I think that's, I think they need to do some work before, like some practice runs. They need to do something leading up to starting things up again in June, and just requiring full vaccination of people coming onto the ship
I'm
and
seeing-
their
I'm seeing
crew
one of
also.
oh, okay. One of our members did post that the CDC did post the new travel guidelines this morning.
They did?
Yes.
Oh, okay.
So we-
So I haven't seen it and I don't know what it says. Maybe they could enlighten us.
And it's apparently it's also an article in the Washington Post. So I think we'll be seeing all of that. Let's everybody take a look, you know, at the New York Times, the Chronicle, wherever we can, get that information. The other thing, and then about, let's move into the world of those of us who are vaccinated and talk about whether or not, is it safe now for us to invite people into our home who are already vaccinated? And if in fact they are, do you still recommend safe distance and mask wearing? How do we begin to understand, calibrate our own behavior based on what our protection might be?
So the CDC says that it is okay to gather indoors, without masks or distancing. And I follow the CDC recommendations, and we have started to have friends come over for dinner. It is one of the things that I have missed the most in this pandemic. And so we have had, I would say, quite a few friends come over for dinner. We do not distance, we do not mask, we give each other hugs. I have been hugging my parents now. I have not been within 6 feet or even touched my parents for over a year. I'm no longer wearing a mask in their house. I'm no longer distancing. We're just carrying on as normal. And I think that that's a safe thing to do. We have not yet had an unvaccinated, oh no, I should say my son came to live with us for 10 days recently. He's 28, he's not vaccinated. We tested him before he came into our house. He stayed with us for 10 days. I tested him again after the 4th or 5th day. He was negative again. We did not distance or mask with him in the house. So we had all vaccinated people in the house, including some friends of ours, but our son was not vaccinated and we did not have him mask or distance. And I think that that is, that's an okay thing to do. It means you can see your grandchildren. It means, yeah, so.
It's time to insert the Hallelujah chorus.
Yeah, yeah. And I think that things could change
Yeah.
again, but I'm like, the CDC says this is okay. I'm going for it.
So there's a question that takes it just one step further beyond the hug. We've got an OLLI member who said, I'm interested in dating. If I am fully vaccinated and my new friend is fully vaccinated, is it safe to kiss? Yes.
So,
Yes, you think so? Okay.
Mhm.
All right. Then there are other questions which I think you have begun to answer. But one, is it safe to do lap swimming at public pools?
I think so. And I think that there are restrictions now for public pools that only one person can be in a lane. And
Right.
I think that the locker rooms are still closed. And I do think that swimming in a public pool is a safe thing to do under those conditions, even in an indoor pool.
Ah, great. And then everybody's eager to get back out to music and theater venues. Any advice on, I know many of them are circumscribed by their local public health departments, but do you have any advice around going to a theater?
So I don't know of theaters that are open right now, I think that there might be some provision that they could open with decreased capacity. Um, I, I don't know what I would do. I was very happy to see that they opened a clinic in New York for Broadway artists to become vaccinated, because I go to New York every year to go to the theater. And I'm hoping that that's going to come back. I think that probably for fully vaccinated people to go to the theater, as long as it's not at full capacity, is probably an okay thing to do. There's probably a small risk, but it's a small risk, and nothing is completely risk-free unless you were doing, outdoor Shakespeare. It's probably risk-free.
Will the, let me see, I just lost.
But some states, in Texas, they're filling their baseball stadiums. I mean, no decreased capacity. And Texas, by the way, lags behind most other states in rolling out their vaccine. And I think there's going to be a price to pay for this. And I put Texas on my New York Times COVID tracker. Anybody can get a New York Times COVID tracker. So you get an email every day. Pick your states where you have your relatives living so you can see what their vaccination progress has been, how many cases, how many hospitalizations, how many deaths. That's sort of the first thing that I look at every day.
What a great piece of advice.
And I don't think you have to be a subscriber to get the tracker.
And it seems that certainly, I mean, what we're reading about in New York, as you suggested, some of the theaters are being allowed to return to 1/3 of their capacity. Obviously, the theaters are saying back that that's not a financially viable proposition.
Right.
And, one that I can definitely empathize with. But I think that I think it's going to be kind of informed by the local jurisdictions oftentimes. What's possible. I know giants.
Right. And I think if in New York they are allowing decreased capacity or decreased numbers of people in the audience, I think that might be going away because of the rapid rise of cases now in New York and in the tri-state area, actually. So I think that might be closing down again. Any changes that are being made by local jurisdictions, state departments of public health can always be retracted as conditions change. And that might happen if we go into a fourth wave. I have to say, after the third wave, we learned a lesson that if the cases are not really, really low and you start opening up venues and loosening up restrictions on masking and distancing, then, look what happened to us. We got the fourth wave, which was absolutely huge. I mean, the third wave, which was absolutely huge. And now the cases we never got very low. We're still at 66,000 cases a day, 70,000 cases, even 77,000 cases a day, which is where we were at the peak last summer. And now states are opening up and pulling back mitigation measures. And that's why I think that with variants is why we're moving into a scary period where we may be seeing a fourth wave, unless that vaccine can be rolled out extremely rapidly.
Some members are really concerned about going into Uber and taxis with an unvaccinated driver. Do you have recommendation around increasing the safety and reducing the risk?
Yeah. So so there was a study that was done by an engineering department at, I want to say Texas Tech. I can't remember exactly what academic institution did this study, but they did modeling looking at the transmission of a potential coronavirus in a car. They used a Prius as an example, a car going at 50 miles an hour. So the worst situation was the car going with all the windows rolled up the driver in the driver's seat and the passenger in the on the opposite side in the back seat, which wasn't 6 feet of distance, but was the greatest distance that could be achieved in a car. The safest was to keep all of the windows open. And in that situation, the risk is actually slightly greater for the driver, because as air currents go, the driver actually gets more wind going by than the passenger. But as a compromise, if the driver refuses to have all the windows open, then the compromise safest position would be for the passenger in the opposite side with the opposite window open, and the driver on the driver's side with the opposite window open. So the opposite windows are open on the diagonal, and that's the compromise position. But if you can convince the driver to keep all 4 windows open, that's the safest.
Very good. All right, we've got a few more questions before I quickly look at the chat. And they're, excuse me, they're about the effectiveness of the current vaccine and when there might be a booster. The question is the difference between Moderna and Pfizer and J&J, and any difference in their durability. And if you get, what the timing would be around the booster for the variants. Is there, if you have a Moderna vaccine, can you get a Pfizer booster? Is any of that determined yet?
Okay, so we don't know. That's the short answer. First of all, the vaccine mixing studies are just now starting up, where you might get a first vaccine with Pfizer and a second with J&J or AstraZeneca, or so sort of that kind of mixing of different kinds of vaccinations in sequence. Those studies have started in the UK. But we don't, the studies looking at boosters have just begun in the last month or 5 weeks or so. Pfizer and Moderna are both using a booster specifically aimed at the spike protein of B1.351, the South African variant, which is definitely a variant of concern. And so they are using they are looking at people who were in their phase 1 study who were fully vaccinated with either the Moderna or the Pfizer. And now almost a year later, because their phase 1, actually, they probably are a year later because they did their phase 1 very early on in the year, maybe March. So they're giving them a 3rd dose of the regular vaccine to see if that will boost their immunity. That's one group. They're giving them a 3rd dose of just the booster specifically designed for activity against the B1.351. And then a 3rd group is getting not only a boost with the regular vaccine, but also it's a combination vaccine that contains both the regular and this vaccine specifically designed against B1.351. So we are, and both Moderna and Pfizer are doing that vaccine trial. I believe that J&J is also going, if they're not doing it already, they are working on it and haven't started yet that I've seen in the press or press release. So those trials are ongoing. I suspect that we will have information coming out in the next few months about at least the serological response to the B1.351. I have not seen any booster trials looking at the California variant, for instance. So, but it wouldn't be difficult to create a booster that would have specific activity against the spike protein that's expressed by the Cal20C variant.
Debbie, thank you. The 2-part question, many people have been postponing their surgeries for their hips and knees. And so they're now scheduling it for April and May and June. Do you think this is advisable?
I think it is reasonable. The positivity rate in San Francisco is less than 2%. And in my family, one of my family members were going ahead with cataract surgery that hopefully will be done maybe in this month. So I think it's reasonable to start doing all of those delayed maintenance, doctor appointments, procedures and things now is probably a good window. And that may change. Again, things may change and you may end up wanting to cancel your appointment, but I think it's reasonable to start doing those things now.
What about the steroid injection in knees and hips?
I totally do that. Yeah,
okay.
I would do that. No question about it.
Then one final sort of general question. Is there any change in the demographics of who is getting sick and dying?
So there's a change in the demographic in who's getting sick for sure. And if you look at Michigan, again, as a picture of what we might be looking at, the people who are getting sick and going into the hospital are actually people under the age of 50, because those are the people who are not vaccinated. So people under the age of 50 can get very sick, can be hospitalized, and can die. The CDC put out an MMWR on that very subject maybe 3 months ago, looking at hospitalizations and deaths in individuals between the ages of 18 and 49 across the country. I think there were over 20 states supplying data. And so this is a thing that can happen, and it's happening right now in Michigan. Those are the people who are getting hospitalized, younger people.
You know, there's a couple of questions about long haulers. Are we learning anything else more? I know in my family, my brother had COVID several months ago and still has not had his taste or smell returned and is experiencing vertigo.
Yeah.
How much longer?
So we don't know. We don't even know what the burden of long COVID is going to be, but it's going to be significant. And insurance companies are going to have to recognize this as a real thing and not a, anyway, and they're going to have to cover people who have it, because this lasts many months and we don't really know what the endpoint is. There are several academic centers that are studying it, including UCSF, University of Texas, Mount Sinai in New York, and probably several others now. It really requires a village to take care of these people because they have symptoms in many different organ systems. So you need to have subspecialists involved in the clinic in lots of different areas, including head and neck surgeons who deal with the loss of smell and taste. And by the way, there was the daily from this, in the last 7 days, there was a daily on the loss of smell and taste that's worth listening to, the New York Times podcast, because there are ways that people can retrain their brain to regain their sense of smell. But there are, oh, and at Stanford, they're also interested in long COVID. And there's particularly a neurologist who thinks that some of the patients who have long COVID actually have developed POTS, which is an autonomic dysfunction that affects many different organ systems. There was recently a paper from New York about neurological complications of long COVID. And, you know, these patients have lots of different neurological symptoms that persist for at least 6 weeks. But many of these patients, I think the median duration of symptoms was 5 months when they started entering the clinic. It's Northwestern in Chicago. That's where they have the clinic there. And these patients, while they don't have abnormal physical exams, have a significantly decreased quality of life. They have decreased cognitive ability. They have decreased attention span. They're just, the more we look, the more we're finding really debilitating symptoms of in people who have long COVID. And these are individuals who can't return to work or can't return to work as they used to do. So It's very disconcerting and worrisome because when you think about the millions and millions of people who have had infection, even people who have very mild infection can develop long COVID, even patients who didn't have any symptoms with their primary infection can develop long COVID.
Well, more to return to at hopefully our next time that we get together. The question is, it does look like the CDC has issued new travel guidelines, which are encouraging some of our members in the chat room to ask travel specific questions. For instance, if I'm fully vaccinated and I want to go visit my elderly parents in Arizona, who are vaccinated. Is that a safe thing to do? Any recommendation?
So Cal 20C is spreading in Arizona too. So, if I would, I would say that it's okay to visit your elderly parents. You take a little bit of a risk going on an airplane. It's not such a long flight to go to Arizona. I would still probably wear an N95 on the flight. I don't know what the CDC is saying, but especially for a short flight like that, it's not a big deal to wear an N95 mask on a flight. The middle seats are now being filled even by Delta, that I think was the last airline to keep the middle seats open. So expect to be crammed into an airplane with a lot of people who might be symptomatically or asymptomatically infected and who are flying to where you're flying, and you might be sitting next to one of them. So I think it's reasonable to take precautions, but I'm very curious to see what the CDC has to say about this.
Okay, someone was asking for a distinction between T cells and the T cell responses and antibodies.
So there are two arms to the immune system. There's the humoral immune response, that is the B cells that produce antibodies, and then there's the cellular immune response, and that's the T cells that produce small molecules that also mediate, that can also fight infection. The reason that most of the papers look at antibody response is that it's really easy to measure it. And so we are using it as a surrogate for how robust a response is to vaccine and how durable, because it's super easy to measure antibodies. It is not easy to measure T cell responses. It's very labor intensive, it's slow, it's expensive. So while there were limited studies of T cell responses in the phase 3 studies, and there are far fewer papers that have been published looking at the cellular immune response to vaccine, again, because it's really not easy to measure it and because it's slow and it's expensive. But there are some papers out there that show a good T cell response, and the phase 3 studies showed a good T cell response to both mRNA vaccines and also to J&J.
And I think as I'm looking through the chat questions, Debbie, I think people are talking about their own particular instance, being fully vaccinated, but still concerned about how exposed or unprotected they might be. Someone, again, another person who just has one kidney, concerned, are they in that category where they need
No.
Okay. Oh, good. Excellent. Okay. And then I think we're managing to get through most of these questions. Debbie, is there anything, as we're approaching 11:30, anything advice that you would give around how we proceed over the next several months? I would very much like to have you come back over the summer, June, July, for us to get an update. I know
Sure.
that you always, when you are presenting at the Maven Project, say this information is what we know today. And there's such a vast amount of research and practice going on that things do change moment to moment, and staying on top of it is really important.
So that's what I would say, that you just have to read the paper every day. Things that are important get into the New York Times, they get into the Washington Post, they get into the Chronicle, and you just have to read and keep on top of it so that you know when things are starting to change and when recommendations are starting to change. And, you know, if the CDC says it's okay to loosen up on travel, I loosen up on travel. If the CDC says it's not okay and that you should tighten up again, I would follow what they say. I really have a lot of confidence in them now and feel like they're back. And I look to them as a very valuable source of information, and I would recommend that you do the same.
So we can return to dining outdoors and in some instances indoors. The outdoors, even if we have an unvaccinated member of our family, if
I
we
think outdoors is okay. I'm not sure I would do indoors yet. That it's the indoor dining and the indoor bars that have been sources of spread. So if there were a way just to have fully vaccinated people eat indoors, I think that would be preferable. But I don't know. I think there's a little bit of risk eating indoors, especially if the establishment is not adhering to distancing guidelines and capacity guidelines. And so I would just sort of keep that in mind.
Debbie, our hats are off to you. Our hearts are appreciative. You are an enormous source of inspiration, knowing that there is a way of looking at our current circumstance and starting to live a more normal life. So thanks for all of the information and all of the best practices. And everyone, I hope you have a wonderful beginning to your spring. Thank you for the first week of OLLI classes. It really has gone well, and we look forward to the ensuing weeks of the spring term and the summer. The summer program is on its way to you, so take a look. And Debbie, again, thank you.
You're welcome.